I think that what we need to do is, first of all, take the research evidence that we have about nutrition and lifestyle priorities for type 1 diabetes and type 2 diabetes or prediabetes separately, because the evidence is different. And then once we have that evidence, we need to evaluate each patient individually, their clinical profile of how that looks, what's in most need, the ABCs of diabetes control, A1C, blood pressure, lipids, and then look at the current eating habits of that particular person, see how they align with the nutrition priorities, and then the most important phase is to come up with a tailored plan to take those nutrition priorities and put them into an action plan that patients can really follow and they find doable. I think too often we try to give the same cookie cutter approach to patients, to say, here, you have type 2, here's your sheet, this is what you need to do. And the same diet does not fit all, and the same strategy does not fit all, because patients have different learning capabilities, learning styles. Well, I think with type 1 diabetes, the evidence is really around consistency in diet, consistency in carbohydrate intake, and I worked on the diabetes control and complications trial, and we found out from that study, in the context of intensifying diabetes therapy, that there were really 6 diet behaviors to focus on, and each of those diet behaviors was associated with a 0.25 to 1 point lower hemoglobin A1C. So as I approach patients, I try to focus on those 6 diet behaviors. Well, the first is consistency in the diet, mainly carbohydrate intake. The second is learning to adjust your insulin for changes in food intake to match that. The third one is to avoid overtreating hypoglycemia. Patients tend to overtreat a low blood sugar because they feel uncomfortable and then their blood sugars go too high. The next is to respond promptly to high blood sugars. They can do that by taking a walk, by eating a little less food, or by responding with an insulin correction dose. And then the fifth one is consistency in nighttime snacking habits so that they have a stable overnight blood sugar. And the final one is avoiding extra snacking, because of course that would elevate the blood sugars and affect the overall A1C. So focusing on those 6 behaviors can make a big difference for patients, and it simplifies the message. That is the key issue, is that people are busy, and diabetes is a demanding self-care condition. And so what I try to do is give people 1, 2, or 3 individualized strategies to work on that they find doable. And I think the key thing that any healthcare practitioner could take away is to say, if you've given someone some instructions of what to do, to ask them before they leave the office, how doable is this for you? Out of 100% confidence, how confident are you that you can do this? And nobody does that. And people walk out of the office and they hang their head and go, oh, can't do that, forget that. But if you ask the question and people say less than 80% confidence, I tell them, okay, it's not a good plan then, because it's not a good fit for you. So let's renegotiate and come up with steps that are doable for you. So then people have hope that they can make progress in a busy world and a busy life.